including ones as prevalent as prostate cancer, as chronic diseases that can be managed over time. Ideally, all cancer patients should be able to benefit from these latest innovations in both diagnostics and treatment. But as you well know, ladies and gentlemen, that's not always the case. And that's why we've convened today's panel in the run-up to this year's American Society of Clinical Oncology annual meeting. What factors hinder patients from obtaining information that enables them to understand their condition and to express their individual preferences on treatment? What can members of the oncology community do to overcome these barriers and to boost access to innovations in cancer care? Those are our key questions, and we have an outstanding lineup of speakers to address them. I'll introduce them in just a moment, but let me just say beforehand that although we're meeting virtually, we want to make our discussion as lively and interactive as possible. And that's where you come in, ladies and gentlemen in the audience. You can share your questions and your brief comments using the chat function on this live stream. And let me just add that there's also a silver lining to the fact that we're virtual. This technology is allowing us to link up oncology innovators and audience members separated by thousands of miles and hours of time zones. So now let's get started. It is my pleasure to introduce each of our speakers, and I'm going to ask each to tell us in his or her words in one sentence what they hope this event will achieve. And I'll start with Dr. Ryan Huey. He works in the Department of Gastrointestinal Medical Oncology at the University of Texas world-renowned MD Anderson Cancer Center. Dr. Huey, what are you hoping and expecting from this event?
Thanks, Melinda. I think this is a great opportunity to listen to patients and advocates to hear about how these advances affect people every day.
Thank you so much. And we'll move right on to a patient, and that is Brian Rodriguez, diagnosed with fibrosarcoma as a child, experienced a relapse in 2019 after more than 20 years of remission. During that time, she had become a nurse for pediatric oncology. She was treated after her relapse with precision medicine following genomic tests that revealed NTRK gene fusions. She'll tell us more about her story later on, but Brianne, please share your hopes for what today's event can deliver.
Hello, everyone. In general, I think just being able to continue to spread the word, all of these people joining the call can continue to spread the word.
Thank you. That's great. And I'm also so pleased to introduce Joel Novak. He is a highly respected patient advocate who has 5 different primary cancer diagnoses, including metastatic prostate cancer. He's CEO and co-founder of the nonprofit support organization Cancer ABCs, and he also sits, amongst other organizations, on the Department of Defense Prostate Cancer Research Programmatic Committee. So please, Joel, your quick message on hopes for today's event.
Sure. Thank you very much. I hope that today our listeners will learn that everyone's cancer is different and that everyone's decisions, therefore, need to be different.
Thank you. Very interesting. And finally, it's a pleasure to introduce Robert Lacaze. He's member of the executive committee of Bayer AG's pharmaceutical division and head of the oncology strategic business unit with responsibility for global oversight of Bayer's oncology franchise. And Robert, please give us both your quick take on expectations for today and also then share Bayer's perspective on today's topic as a whole.
Thank you, Melinda, and it's a pleasure. And first of all, thanks for everyone joining the LinkedIn conference today, and welcome to all of our guests. I'm looking forward to hearing from you, because I think for me, one of the key takeaways is going to be the constituents, the people who are dealing with cancer every day, the patients, the patient advocacy, our physicians, and understanding some of the barriers that we can work together on to try to remove to ensure that patients can get the proper care that they need. This year's theme of ASCO is equity, every patient, every day, everywhere. And I think that's a very appropriate theme as we think about what we need to be doing as a collective oncology community to help ensure access for patients. Now, I don't really need to go through all the numbers, but while there's been a lot of progress that's been made in the recent years, Still yet, cancer last year was estimated to cause about 19 million new cases, a little over 19 million new cases, with approximately 10 million deaths from cancer occurred in 2020. And if you actually just go out 20 years, that number globally is expected to rise by 60% or close to 30 million new diagnoses by 2040. So there's still a lot of work that needs to be done. And while over the last decades, there's been a lot of achievements made from early detection, better treatment options, better diagnoses, more precision medicines, new immuno-oncology type of medicines, there's still a lot of room for continued improvement. And today it's estimated that around 33 million people are living with cancer worldwide, which means that a lot of patients are surviving. But it's not just good enough to survive. We want to make sure that patients are surviving with a good quality of life, and we want to make sure that as we're looking at access, that patients can get access to these medicines. And the evidence is very clear that patients who actually get the proper care, whether it's an early diagnosis or early intervention, or even in a metastatic setting with the right proper treatments and access to these treatments, it can have a really important, significant impact on their outcomes. And outcomes are just not for the patients, obviously, but it's also for the patients' families. And to Joel's point, cancers are different. Individuals are different. There's different needs, different approaches that need to be made or need to be had to make sure that we can maximize the benefit for the patients that have the greatest needs. And we at Bayer are really focused on that, whether it is a fairly prevalent tumor like prostate cancer, to even extremely rare tumors and somewhat difficult to treat, such as tract fusion cancers, and oftentimes even difficult to even identify. So the diversity of these cancers just really reinforces the need for a global effort to control the disease. Now, the barriers that contribute to some of the patients not being able to gain access can be quite significant. And when I say access, it's not just access to medicines, it's access to optimal cancer care overall. And some of these are just lack of awareness, maybe the geography, social, economic status, sometimes a lack of infrastructure, and sometimes it's even the mismatch between a regulatory accelerated approval versus a HTA assessment that are not always linked up to the unmet medical need and the benefits that the medication can bring to the patients. So, working together to try to integrate regional and national healthcare planning to reduce the burden and the suffering worldwide is something that's really important to us at Bayer. And so we're committed to this, committed to breakthrough innovations, committed to bringing the right medicines, as we've heard, the right medicines to the right patients at the right time, and working with the overall medical community and the oncology community to do that. So with this, I'd like to maybe turn it back over to you, Melinda, and I would really like to hear from our panelists on some of their views. And this is, again, this is a very, very important topic for us at Bayer. So thank you.
Thank you very much, Robert. And you've set up our topic very well indeed. We'll be picking up on a number of the points that you just made. And ladies and gentlemen, we will now move on and hear initial inputs from our other speakers as well. And while they are speaking to us, please send us your questions and comments, because after that, we'll go straight into our interactive panel. And we are very eager to pick up on your own questions and insights, as well as the points that Robert has just made and that we will hear now in the following inputs. So I would like to ask Ryan Huey now to please share your view on disparities in patients' access to innovations in both diagnosis and treatment. Some of them mentioned there by Robert, but I know you have extensive experience in this area as well. And perhaps say a little bit also about what physicians can and should do to empower patients.
Thanks, Melinda. Very happy to be here today and to talk about something that I find really important for the treatment of patients and for quality of life overall. I think this is important to oncology as a field, but again, mostly important to individual patients. And so I just have a couple of slides. The first slide is really just talking about three major points behind precision medicine and barriers to care. And so the first is that you can't use data that you don't know about. There's an increasing number of clinical trials open to patients with specific mutations in their cancer, and therefore an increasing number of targeted therapy drugs that are the standard of care as well. So one step to ensure that patients maximize their opportunities to treatment and clinical trials is that they have access and availability to genomic testing of their tumor to see if there are mutations that are driving the growth of that cancer. But there's some inconsistencies in some of the testing and some of the access for patients. Well, why is this the case? Well, for starters, while some cancers have mutations that drive treatment, others generally don't. In addition to that, the most appropriate time to test varies between cancers. Some cancers you need to test early, others it matters for later lines of therapy. And so there are differences. It's not universal across all cancer types. In addition to that, if patients don't have access to clinical trials, their physicians may not test them in the first place. If we really think that this is the barrier, this is the key to clinical trials, and those trials don't exist in the first place, then the testing may not happen. So what do we know? Well, we know that unfortunately some racial and ethnic minorities have lower rates of testing than the general population at large. And in addition to that, in the United States, some patients with certain health insurance plans can have lower rates of testing as well. So the bottom line is, we know that genomic testing is a problem, particularly for some groups, but if you don't test a tumor, then you ultimately can't treat based off of that information. Another point is you can't study patients who aren't there. So we have repositories like the Cancer Genome Atlas that molecularly categorize tens of thousands of cancer. This is a database that's important for research, preclinical studies, and ultimately the development of the next generation of cancer treatments. Well, what's the problem? Well, the majority of these patients, 77% in fact, are Caucasian. And this leaves many groups across the world as being understudied. It is possible that this creates blind spots to the development of biomarkers and drug targets for certain racial and ethnic groups. And so you can't build a research program for all patients if many of them are excluded from the ground floor. Another form of exclusion, and the last one that I really want to talk about, that serves as another barrier of entry into clinical trials is the last point. Clinical trials, unfortunately, don't come with a free lunch. So financial toxicity is a concept that's been studied in cancer treatment over the past decade, but this also affects people in clinical trials. There's extra visits and tests, and often patients must travel farther in order to receive their care. We did a study that looks at out-of-pocket costs for patients enrolled in clinical trials. We found that half of patients spent over $1,000 monthly on non-medical expenses. So there are absolutely patients who consider these costs before ultimately turning down a clinical trial. So one thing we're advocating for is funding for reimbursement of these costs so as to improve access to clinical trials. These are not patients who are padding their pockets with extra cash. These are patients that are spending this money in order to be able to receive their cancer care. And so we think this is unbelievably important for everybody to get their most appropriate and individualized care. The second topic that I really want to talk about today is communicating value to patients. So I tell my patients that I want them to live as long as possible with as good a quality of life as possible, especially in cases where multiple treatment options are available. A nuanced conversation that involves the discussion of risks, benefits, and side effects is unbelievably important. And ultimately, this speaks to the true value of a treatment to a patient. As was mentioned, prostate cancer is a very good example of this. It's the third most common cancer diagnosed per year worldwide. And I think there are a couple of illustrations, both with early stage prostate cancer and later stage, that really kind of depict this. So the thing that I want to draw your attention to on this slide is on the right here. We call this a radar plot. So for early stage prostate cancer, many of these men will consider the role of radiation therapy or of surgery, conceivably of brachytherapy as well. For each patient, you need a thoughtful conversation with a surgical oncologist with a radiation oncologist, and with the whole team together. But these are nuanced decisions. There are trade-offs. And so some patients may want to receive their care as quickly as possible because getting back and forth to a particular treatment on a daily basis is really cumbersome or difficult. Others may have preferences in terms of wanting to make sure they avoid urinary bother and urinary symptoms. Still others may consider bowel symptoms or bowel bother, diarrhea as well. And so one of the ways to display all of this data is with a radar plot. Some of the individuals that I've worked with have developed this, and it's really designed to show different domains at one time. The domains are basically weighted between 0 and 100, with 100 being further out from the center of this circle. And you can see that there are 6 categories here. These categories are looking at things like urinary incontinence, sexual function, even value, which is the yellow bar that you can see. And the further out you get from the center, the better the value is to patients. The point is not to walk through the nitty-gritty details of this so much as it is to suggest that these treatments have trade-offs, and it's very important for physicians to have these conversations with patients, number one. And number two, it's important for us to visualize this data and help patients understand it. Now, I'm not going to show this to a data visualization professional and have them blown away by this diagram, but we have to start somewhere in medicine. And I think that using radar plots like this can at least help us begin to have that conversation. The other thing is that, there's another example with later stage prostate cancer, patients who have a PSA recurrence after their initial treatment. And these patients are often treated with hormonal therapy. But over time, we've learned that hormonal therapy comes with side effects that men don't love, to be quite frank. And so we have developed different ways to treat patients. In fact, one of those ways is to do hormonal therapy for a period of time to maximize the benefit of that treatment and then to take a break. I often tell my patients that as things go well, we bring treatment options onto the table. And sometimes those treatment options are as simple as taking a break from therapy. The benefits of that being fewer side effects, improved quality of life, and making sure that we are providing care that is consistent with the patient's values. And so, again, I think these are unbelievably important conversations to have with patients. I think this highlights a very simple way that we can optimize the care and personalize it for each and every patient. And I'm excited to hear what our other panelists have to say as well. Thank you very much for having me.
Thank you very, very much. A number of very interesting points there, and I hope that also Brian and Joel, where it's suitable and you wish to do so, perhaps you can also pick up on your personal experiences in some of the areas that Dr. Huey just talked about. So let us now, in fact, move on to these personal perspectives on precision medicine opportunities and obstacles. And I'd like to start with Brian, if I may. And Brian, I told a little bit about your story, but perhaps you can share more, especially in regard to your experience with state-of-the-art genomic testing, something that Dr. Huey just talked about. What barriers did you experience, and is this something you would advocate for other patients?
Of course, yes. Thank you so much for having me. So I know Melinda touched base quickly, but I do want to share a little bit more about my own cancer journey and then just some final thoughts. So, for me, genomic or biomarker testing really changed me and my family's entire life trajectory. We went from a very sad, dismal place to one filled with a little bit more hope. So yeah, that's why I'm just so pleased to be here and just share more. I was diagnosed with fibrosarcoma of the right hand as a child. After failed chemotherapy, I underwent right hand amputation in 1998. And then shortly after celebrating 20 years in remission, in February of 2019, I learned of my recurrence with stage 4 soft tissue sarcoma with metastatic disease to my lung and my pancreas. And this was further complicated because I was pregnant with my first child at the time of relapse. So knowing that sarcoma is typically resistant to both chemotherapy and radiation therapy, Biomarker testing was immediately sent off, and the NTRK gene fusion was noted. And then in April of 2019, I was able to deliver my baby girl at 28 weeks so that I could start therapy. And days after I delivered, I took my first dose of my precision medicine, which is a TRK inhibitor. And so to date, it's been just about over 2 years since I started therapy. My disease is stable. Our daughter has also grown to become a healthy, happy toddler. And I'm feeling well, which I think is important. I don't have, significant side effects. And this allows me to be, the best wife and mother that I can be. So having time to reflect over the past 2 years, I realized that I didn't really have that many barriers. I was fortunate. I, had established care with a team of doctors that knew to biomarker test right away. There was no delay. There was no unnecessary chemotherapy or additional suffering from that chemotherapy. We were able to target my cancer right away before it grew or spread even more. And without this, and without biomarker testing, I know there was no guarantee that my length of survival would have reached this far. And so, again, I had the means to travel to an academic hospital in a big city. I'm a nurse. My husband is a doctor. We have the knowledge that, allows us to be our own advocates. However, after reflecting, I'm realizing that I'm the minority. The majority of these patients don't have these things on their side. And I guess, that's why I'm here today and why we're all here today. I'm passionate about the importance of widespread genomic testing and trying to identify other patients that are eligible for precision medicines. I've also joined a nonprofit, NTRKers, as a board of directors member, and our efforts do include increasing testing knowledge and support. And what I think we can do is, like I said, spread the word and also educate. We need to educate not only patients, but more healthcare providers, those in the smaller settings like community hospitals. And I think we even need to reach out to lawmakers. Like newborn screening, where each state has a law that requires testing all newborns, why can't we do that, for those with cancer? The more people that understand the benefits of early diagnosis, the more lives, will be saved and morbidities reduced. So obviously, that's something that should be done.
Brianne, thank you so much for sharing that very powerful and moving story. And I'll just confess to the audience that we all got to virtually meet Brianne's daughter on our last call, and she's just an absolutely beautiful toddler. So thank you for telling that story. And let us now get an additional personal perspective from Joel Nowak. And please, if you would, Joel, share not only your cancer journey, but also your reflections as a patient advocate. What's your experience, for example, in regard to patients' desire for a stronger voice in treatment and quality of life decisions?
Thank you so much for including me. And I just want to say that I really appreciate the comments of the two prior speakers. You guys are amazing and you have great insight. I think it's very important that patients become much more involved in their own personal care, that they take personal responsibility along with their physicians, their whole clinical team, in making decisions about what's important for them. Why is this such an important factor? It's important because each of us, as we have a different cancer, we also have different goals and aspirations of what's important to us. And what's important to me is not necessarily going to be important to another patient. So it's only by my first becoming educated as much as I possibly can about my specific cancer, and then thinking about and spending time trying to figure out what's important to me as a patient by consulting with my family, thinking about what I want to do, where I want to go, what I want to have happen to me. Can I understand what's important? And the two big decision points that I think that most cancer patients will face as they make treatment decisions with their physicians is going to be quality of life versus extension of life. And there is no right answer, there is no wrong answer. And for each patient, the right answer is their answer. It's not my answer, it's their answer. But it needs that to take self-reflection and spending time to think about what in fact is important, and then making sure that their physician know and understand what's important. And the only way that can happen is by having good communication with their physician. And that means telling their physician what's important and what they want. Now, the best way to do this is to do it after you've educated yourself so that you understand options and can have a better conversation as you make your treatment decisions. I think from a psychological aspect, one of the aspects of cancer is depression and emotional responses and anxiety, all sorts of things like that. But it's through taking control of our own body, through our treatment decisions, along with our physicians, we can actually gain some control back and not let cancer control us. And I think that's really an important thing. As I mentioned in my introduction, everyone's cancer is different. I think we've already reflected that each of us are different. So the decisions are not going to be the same from one patient to another, even with all the other same circumstances. One of the big barriers that I think we have as patients is that we don't always speak the same language as researchers, and we don't speak the same language as our physicians. It's almost as if at times there are three languages going on. And so we have to find a way to basically be able to communicate with each other, that patients need to be able to read research and understand it so they can engage in a better conversation with their doctors. Doctors need to understand that when they're sitting there with their patients may not understand all those big, funny words. And I think that we need to find ways for each of us to come together to check out, do you understand what I'm saying? Do you hear what's important to me? And it's only through communication and checking things out. Better information leads to better questions, and better questions lead to better outcomes.
Thank you very much for that, Joel. And let me just ask you, you talked about the importance of words. There's one word I left out of my introduction because I thought you would probably use it if you told us a bit about your journey. But in fact, you've given us a wonderful, articulate statement about what patients need. But talk to me a little bit about thriving. Because okay. When we had our first conversation, you talked about being a cancer thriver, and I found that very intriguing.
Yeah, thank you so much for asking me about that. I think that just because we are diagnosed with a serious illness, including cancer, doesn't mean that our life has necessarily come to an end. I think that for many people, they got mucked down or mired by the thoughts that they may have, their emotions. And we use language, again, going back to language, to sometimes express what we're trying to do. And I find that a lot of patients or the world uses the word being cancer survivor. Well, survivor to me means I'm keeping my head down, I'm in a trench, and the gunfire is shooting over my head, and I'm getting along and trying to figure out, how to live the next day. Well, for me and for the patients that I work with, I don't think that's enough. I think we all have to live our life to the best that we can, and that's through finding a way to thrive. Each of us have to find our own way as to how we get there, and there's no one story. I will say that just briefly, because I didn't discuss my journey, when I knew I had a metastatic prostate cancer reoccurrence, I thought that I was going to die within 5 years. Now, I want to share with you that was 16 years ago, and I'm still very much here and still very much alive. And the quality of my life has I've done things and made decisions that will protect the quality of life. My own personal thing is my quality of life is more important than my life extension. I'm not complaining, however. I'm 16 years metastatic, and I'm still very much here, and I consider myself to be a healthy man. But we each need to find a way to live a happy and joyous life, a life with hope. And it's, in essence, to find a way to thrive despite having cancer or despite having any serious illness. I hope that's been a little responsive.
Very much so. And thank you so much, because I think we want to talk not only about the what and how of precision medicine, but the why. And you and Brian have made it very clear to us what is this about? Why is it important that as many patients as possible have access to these choices? So let us move on now to our interactive discussion. And I have one question that has come in, and I'm hoping to get more. Dear audience members, please do use our chat function to send us your questions. You see I have my glasses on now, so I can read every word of what comes in. And our first question, I think, is intended for Robert, but if anybody else wants to talk about another dimension of this, please give me a sign. So the question is this: there's a huge budget impact for payers when it comes to advanced therapeutic medicinal products like gene therapy. And of course, Dr. Huey mentioned this as well. Added requirement for diagnostic tests have an organizational impact, requires trained staff and infrastructure. What initiative is being taken by Bayer to support diagnostics to deliver the right treatment to the right patient?
Yeah, so thank you, Melinda, for the question and who sent that in. There's a lot of things that are being undertaken from a Bayer standpoint. Some of the things that we're doing is, first of all, we need to understand the different countries that we are actually having our products that are available in. Every country is different with the access to genomic testing, for example. The guidelines are different, so we're working with policymakers to try to standardize some of the guidelines that make sense for the different tumor types, if you will. We are actually partnering with some of the companies where it's extremely important from a testing standpoint to ensure that the patients, very similar to Brandon's point about sarcoma, where there's very few options that really work. But if you actually have a certain type of mutation and you can identify that mutation, you can potentially have a very effective therapy. And so we are actually have partnered with certain diagnostic companies to even make some of these tests available fairly free of charge to ensure patients can get access to those, which I think is very important. There's a multitude of things that we're doing when we're working with the. If you were to look at the U.S., for example, where you have a lot of the big diagnostic companies that offer the standardized tests versus other countries where you may have a lot more of the diagnostics being done in the hospital. And so they have maybe an individualized approach. So understanding that system and being able to work within that system to ensure that the appropriate markers are actually part of their test, to ensure that as therapies become available, the test is actually potentially picking up the markers for these particular therapies as well. So it's a broader array. There's no one size fits all, but really understanding what we would do in Brazil versus in China versus in Japan, Europe versus the U.S. is we're taking a very, I would say, a very precise approach to how in working with the hospitals, the physicians, the local policies and politicians, and the healthcare providers to ensure that we're meeting the needs. What I would be interested in is, Dr. Huey, being down in MD Anderson, and you're looking at, as you're thinking about the testing and the diagnostic component, I'd like to understand a little bit more from your perspective, from a healthcare system standpoint, maybe how you would think about, what else is needed from either from a policy standpoint, from a payer standpoint, or even from a government or industry standpoint, that we could work better together to ensure that these tests are available for patients.
Yeah, no, thank you, Robert. I appreciate that question. I mean, you raise an important point, right? I mean, these tests are there's different access to these tests for different people, depending on where they live, depending on who their physician is, depending on what their health insurance is, particularly in the United States, right? And so some patients have some patients have all of those things that check the box, so to speak. They They go to the hospital where it's standard of care to get as much testing as possible. They have a lot of clinical trials at their fingertips, et cetera. Others maybe not so much. And so I think that there's a big role, certainly from a policy perspective, in making sure that genomic testing is paid for by payers across the board. I think from a research perspective, we have a responsibility to make sure that we find treatments that benefit more patients, right? We don't want to spend a tremendous amount of money and only benefit a small handful. Though the small handful is important, to be very clear, we want to make sure that we can benefit as many patients as possible. And I think so these are a couple things just off the top, and so those are the types of things that we think about. It's what's challenging as well is there are, to your point, multiple companies that do these testings, and we want to make sure that patients have access to this information as well, and that if they go get a second or a third opinion, that this information is transparent, is easy to access, and so there's not a duplication of tests, because the last thing we want to do is run up the bill unnecessarily. We want to make sure that these tests are easy for everyone to have the information at their fingertips. There's no point in testing if you can't ultimately get the result and act on it. And so there's a big issue with healthcare transparency as well. And so lots of different issues to bring up. And I think we have a lot of work to do. There's no question about it.
I saw both Joelle and Brianne responding a bit, at least in terms of facial expressions, to what they've just been hearing. So let me ask whether either of you would like to talk about the cost side of things. I know that Brianne said that she felt she'd been very, very lucky in the extent of access that you had. But perhaps either of you, if cost was an issue, or if you're seeing that be a major issue for other patients, that would be one aspect. And the other question that I would have beyond just costs alone, whether you feel that patients are being adequately heard by the health system and health technology assessment bodies. So whoever wants to get us started, Joelle or Brianne, please.
Sure. I'll throw in first. Just like Brianne, I've also been very fortunate because I've had excellent healthcare insurance, and except for an occasional issue here and there, which we've managed to work through, I have had access to this stage of everything that I wanted. But I also know that I am very much in the minority, and it's very concerning to me because I'm thrilled and pleased for myself that I have that privilege, but I also know that there are many people who don't, and it's frustrating that we can't become more universal and find a way to extend these treatments that we know that work, that extend people's life. Why is my life in essence worth more than someone else? There's no really good reason. I will tell you that I get frustrated when I am working with a patient who's not in the United States, and in many cases within prostate cancer, we have approvals for treatments for prostate cancer that have not been approved in other countries. And these drugs, or treatments, or tests are just not accessible to them. And then, of course, we have the racial barriers, and economic barriers. I mean, we do have to find a way to be fair in how we distribute healthcare. And I understand that that means that I may get less, and I have benefited from it. But I think we all have a responsibility to each other. We're all people, and we need to be supportive of each other.
Thank you. Brianne, do you have thoughts on that point that you'd like to share?
Yeah, I agree. I couldn't have timed my relapse any better because FDA approval was already in place. So with that being said, health insurance coverage, was good. And there was already a lot of programs established to help, with copays or biomarker testing, things like that. But, what about those patients that, are in the gray area? I don't know, that's why I think it's just, trying to raise awareness, sharing insight about these particular copay programs or assistance programs. Yeah, I don't know. And just in general, I guess, I'd like to see people getting tested right away. Like why let them, relapse, or why let them become metastatic? Let's fund this at the start. And so, yeah, I mean, some of those things, they feel somewhat over, my head or my ability. But I like to just try to raise awareness. I feel like that's the best I can do.
Thank you very much. And you're doing it very effectively, I must say. Joel, you'd wanted to add?
Yeah, I would just like to follow up on that great comment. I think that within prostate cancer, since we're talking about that, our failure often to provide PSA tests, I think, has created a problem because we're finding that more and more people are diagnosed with metastatic disease. If we can diagnose cancers earlier, in most cases, despite what we read, I believe, and certainly the experience that I have had, is that we can better treat people when the cancer is still contained to whatever the original organ the cancer has come from before it's become metastatic. So we really need to find a way to perhaps do better screening, to perhaps implement what we can do earlier and more often at the appropriate places, and to make an investment there. Perhaps that investment would make better return for us than in other places, because the goal here, I think, would be to try to help people contain their cancer earlier on, so that ultimately, I believe that our costs for treatment will actually be less.
Mm-hmm. Thank you very much. Joel mentioned a moment ago the international side of things. So, Robert, we have a question that's come in on exactly that point, and I'd like to put it to you if I may. And it reads as follows. How can pharmaceutical companies help ensure equitable access to innovative treatments and diagnosis for all globally? There's no one approach to this problem. There are different obstacles in each country and sometimes each region, even in the same country, even though cost and reimbursement tend to be common. Thoughts on that?
Yeah, so, and again, there's no, I think the question is almost phrased as a question because there's no one size that fits all. And understanding the different healthcare systems, the different healthcare technologies are very, very important. It even begins as a pharmaceutical company, even as you design your pivotal trials, in terms of ensuring that you not only are delivering the regulatory endpoints that would be required for a regulatory approval, but also designing endpoints that are patient relevant, that are important to patients, but also is important to the healthcare assessments. And that is something that, within the industry that we certainly try to do. However, one of the issues that we run into is oftentimes the regulatory bodies, such as the FDA and EMA, they have accelerated pathways. So in a high unmet medical need where there are no options for patients, oftentimes drugs can be conditionally approved, if you will, until you can have a broader full approval with these important medicines. And in the U.S. that works quite well, and from a reimbursement standpoint. But in other parts of the world, that doesn't work so well. One could receive the approval for the compound from a regulatory standpoint, but then it doesn't meet the requirements from a reimbursement standpoint. So there's a disconnect in certain parts of the world, in Europe specifically, where oftentimes the reimbursement will not occur on an accelerated approval. So patients are having to wait until the full approval comes in order to get the appropriate reimbursement. So I think there's opportunities for the companies working with policymakers to really look at these things to say, okay, where are the barriers that we can help remove, knowing that we still need to do the big phase 3 trials to have the unilateral to provide. But why make patients wait for a long period of time until a 2-year or 3-year phase 3 trial is conducted? And so I think, to me, those are some of the areas that we need to ensure that the industry, not just one specific company, but the industry can work together with our patient advocacy colleagues and our medical colleagues, with the policymakers, to try to address some of these disparities. Now, we specifically at Bayer, we do have other policies in place Whereas when we go to maybe some of the lower socioeconomic countries, we actually have a tiered pricing system that we actually are that we look at from a sustainability standpoint that we implement on some of these lower economic status countries to ensure patients can gain access. So there are things companies can do, and we're doing some of that as well. But there's much bigger issues, and it has to be addressed country or region by region. Although progress has been made, we're just not making it fast enough. Patients, we all know patients don't have the time to wait for these things.
And I have another audience question that's come in on a related aspect. It's short and to the point. Does Bayer have compassionate use programs in clinical trials?
Yeah, so every clinical trial that we do, if it's a really early clinical trial and the benefit of the drug is not yet known, we try to ensure patients have access through the clinical trial itself. As the clinical benefit of the drug is known, we have medical affairs policies that are in place that allows access on a compassionate use basis. We do that oftentimes as we're waiting for reimbursement as well to ensure patients can receive it on compassionate use. Every drug is different. The risk benefit has to be understood, and so as we look at the policies, and you can go on the website because it has it clearly laid out on how we approach that as a company.
Thank you very much. And Dr. Huey, a question to you, if I may. I asked Joelle and Rodriguez Brianne about whether they feel that patients are being heard by the health system and by health technology assessment bodies. Tell us a little bit about how physicians' clinical experience with treatment innovations is taken into account in regulatory assessments. Do you feel that is being adequately factored in?
Yeah, no, thank you, Melinda. I think, this sort of dovetails on Robert's point, right? I think a lot of where physicians come into play with these regulatory bodies is in the initial development of the clinical trials, sometimes alongside the companies that are interested in these drugs as well. But you want to design a clinical trial that has the right endpoint so that if a drug actually does work and you're able to show that you can ultimately get the approval and it can benefit as many people as possible. If you have problems with the design of the trial, you could have a brilliant drug, but the structures just aren't in place for it ultimately to find a place where it can benefit the most patients. And so I think that trial design is really important. The other thing that I think is really vital to this is also making sure that we are measuring the right things that matter to patients, right? And so we care about adverse effects, but not all of these adverse effects are created equal. There are things that a patient feels. There are things that they don't feel that may be lab parameters or other issues. And we can't weigh all of those things equally and pretend like they're all the same. A patient's quality of life is much more dramatically affected by fatigue than maybe what one of their laboratory values is. And so, I think we have to make sure that we have patient-centric measurements and we're using patient-reported outcomes in these things. And that way we can ensure that patients are as heard as they can possibly be. And again, I think a lot of this gets back to design. And so I think that is critical in thinking about, we have to have communication with regulatory bodies up front so that we can measure the right thing, so that if we are successful, we make sure that we don't miss that.
Thank you very much. Yeah.
Maybe I can add a point to that, Melinda, if you would, because I completely can agree with what Ryan is saying there. And I think it's also, as we design these trials, we need the regulatory input, the patient input, and also the HTA input as well to ensure that we're getting those secondary endpoints correct or correctly measured what would be expected. So I think to be successful with making sure that we can get these important medicines to patients, we have to bring all of that together as a community as we move these drugs through development.
Yeah, can I also?
Please, yes, Joel, go ahead.
I think all the things that were said are 100% spot on, but I think we need to figure out and see who our patients are that we're putting into these clinical trials. Not only do we have the racial disparities we know about, but even where we have our clinical trials is problematic. all clinical trials tend to always be in major institutions, academic institutions, and we're definitely coloring the patients who we're bringing into these trials. And we need to find ways to develop an infrastructure in places that we don't have it, in rural areas, in areas where there's larger racial disparities. And we've really not put a lot of thought into doing this, and we've not made the investment. And I would love to see that become a priority so that we can actually get data that really is more inclusive of patients. And we use that word patients, we mean patients, not a specific slice of patients.
Thank you very much. Fascinating. Let me pose another audience question that essentially goes to all of you. And again, very straightforward. What is the single main obstacle to accessing the right treatment from the point of view of the cancer patient, the doctor, and the pharmaceutical company? So let me start with Brianne and ask you, I know that you feel, as we've said, your own course of treatment has been very effective and that you feel very lucky, but when you look at the picture as a whole, how would you answer that question?
Yeah, I mean, I think being able to get genomic testing done on you, period, is probably one of the biggest obstacles. But if we can go ahead and assume that one has been able to, get a biomarker test done or a genomic test done, for me, I think, one obstacle has been just having to travel. I travel long distances to see, my oncologist on a regular basis. And then I travel even further to, get consults about, how we are going to continue to treat this. So yeah, I think for me, it's just the need to travel to these bigger institutions.
Can I just ask you, because we all talk so much and hear so much about remote medicine as a new horizon, is that something that you expect could change that situation, at least in terms of the consultations?
Definitely. Yeah, definitely. I've been able to do some telemedicine, which has been great. But then, other times, of course, one needs to be seen. But yeah, I mean, right, that's possibly one benefit that's come out of this pandemic, is being able to connect, right, over the web. So.
Thank you. Joel, do you also want to give us the patient perspective on that audience question before I go to Dr. Hugh, to Ryan and Robert?
Sure. I think some of the confusion or inability to make a good decision on treatments has something, to some extent, has to do with both the good news and the bad news. The good news is that, again, talking about prostate cancer, we have 7 or 8 newly approved FDA drugs in the United States for prostate cancer, for metastatic prostate cancer. And we're not really clear on how to order those, how to sequence them. We're not clear on what, one drug might build a resistance to another. And so we don't know, again, sequencing, we don't know about combination. So it makes it hard to make a decision. And I think for those men who are diagnosed in an earlier stage, especially initially diagnosed, there are also treatment options, which again is the good news, but it's never very clear to men as to what might be their better treatment. There's so many different factors that they need to consider. And unfortunately, there's really very little places that a man can go to really try to sort out all of the conflicting questions. Unfortunately, in some cases, urologists who are surgeons, they're surgeons because they believe that's what they do is the best. And so they see surgery. And a radiologist, on the other hand, has made a decision to become a radiologist. And so they see that as the best option. And it's not very clear. It's very confusing. And many men go into a real kind of tailspin because they just don't know what's best to do. It's not clear.
Yeah. Thank you very much. That's very interesting. And let me pass the question on to Ryan, and maybe you have thoughts on what we heard from Joel as well.
Yeah, absolutely. I mean, I have to be a little careful and not just come down from an ivory tower and tell other people to spend the money, right, as my solution. I want to make sure that, there is a line between advocating for patients to have access to genomic testing as early as possible, but also understand that there are a lot of actual barriers that are associated with that. It's not as simple as just saying, this is the solution to all of our problems. I recognize why there is why there are going to be some hesitations, particularly to pay for such a thing. I think that to Brianne's point, distance is really important. So distance to clinical trials, distance to the right physician, distance to a cancer treatment center. And so whether that, these costs add up, these time add up, opportunity away from work, childcare, et cetera. And so I think that thinking about ways to make these treatments more accessible where a patient is, or potentially to make it easier for patients to get to the right place. I think those are both solutions that we have to think about. And then the last thing that I think was touched upon is the concept of decentralized care. So to your point, to everyone's point, the pandemic has caused us to think about decentralized clinical trials. Can we get trials closer to patients? Can we get their care closer? Telemedicine can do some of that, but what about some of the blood draws? What about some of the other testing requirements that are required to participate in a clinical trial? So there's a lot of things, but I think now there is an impetus to really think through these things in a lot more depth. And I think that ultimately will lead to greater access for treatments for patients, and ultimately, enrich the knowledge that we gain so that that knowledge is more generalizable to the wider population.
Thank you very much. We have just a few minutes left on the clock, so I want to give everybody a chance. And Robert, I know that I did not give you a chance to address that question, but I'm going to suggest you do it in the context of a final closing thought, perhaps, so that we can still stay within our time frame, more or less. So the final question I'd like to put to all of you, and to some degree you've addressed it, but perhaps you'd like to add something as we move toward the end of our session, would be, what is the one key change that you would like to see taking place in the next few years to support more eligible patients gaining access to treatments and testing that clearly can bring great potential benefit? So Robert, I'll start with you so that if you like, you can kind of link that also to the major obstacle question that we had, and then I'll go on to the others.
Okay, well, I think there's a couple of thoughts around this, and as panelists were speaking, when I look at the one major obstacle, oftentimes it comes back to just knowledge in general and understanding the information available so people can make informed choices. And sometimes the knowledge is, is a genomic test available? If not, is there a way to get it? It could be my treatment options that I have and why. We've all had patients and family members, I certainly have had, and gotten those phone calls when they've been diagnosed with cancer. And oftentimes when they hear that diagnosis, everything else just blanks out. And they, it's really it's a life-changing experience for a lot of patients. And so having to take a step back and really understand what the options are is, I think, is really, really important. And that comes back down. That will come back to information and knowledge. Obviously there's no one size fits all. There's issues depending on which country you're in, which state you're in, and even sometimes which hospital you're in as to what's available and what's not available. So again, it comes back down to understanding the options. Your question, though, if you could just maybe repeat your last.
Absolutely. So the one key change you would like to see taking place in the next few years to support more eligible patients gaining access to treatments and testing that can bring them great benefit.
Yeah, again, it comes back to the benefits of these testing and when do you appropriately do that? As Joel was pointing out, maybe in prostate, it's just more PSA testing. Maybe it's not a genomic test up front. Maybe you don't need that. Maybe you need, but more people need to get screened from a PSA testing. And then if the disease progresses, maybe then that's when you then do the genomic testing. Others, sarcomas, lung cancer, breast cancer, maybe you do need the broader genomic testing up front. So I think for me, the one big change that we need to have is more understanding of the value of these tests. And when to do them, and every tumor type may be slightly different, and to have the optimal care given based on the time that these tests needs to be done. And I've talked to lots of physicians out there, obviously around this, and the tests oftentimes are refer to almost like a roadmap, and it gives me my roadmap of where to go and not where to go, because it helps then me to understand as a, if it was a physician, understand what are the treatment options I need to be making available with the discussions with my patients. So I think that one key understanding is going to be the continuation of the education around these tests and when to do them at the specific tumor type.
Thank you very much. And I want to give our other speakers an opportunity as well to answer that one big change question and give us a final thought. But let me just say to all of the audience members, you are still sending us questions, and that's wonderful. But unfortunately, our window of time is rapidly closing. So I'm afraid we won't be able to take more audience questions. But thank you so much for your contributions. And we will definitely be passing on these questions to the participants anyway. So now let me go to Brian and ask you for just your one closing thought on that single biggest change you would wish to see.
Yeah, thank you. So we have lots of work to ensure that all patients have access to treatment opportunities, an increasing number of which are unlocked through genomic testing and precision medicine. And I just think that the role of clinical trials and access to clinical trials cannot be understated, as these are ultimately the things that lead to more treatments for even more patients in the future.
Thank you. Brianne?
Yes, thanks again for having me. And I think, just again, raising awareness, educating and connecting with others more, whether it be through social media or patient advocate groups, just getting the word out.
Joel?
Yeah, I think I have to come back to patient-doctor communication and education. I think is really important. They each need to understand. As I referenced before, they each need to speak the same language, and there are ways to do that. We need to educate patients about their cancer. They need to be more comfortable in actually engaging their doctors, and the doctors need to be more accepting of the fact that patients should be involved in their decision-making, because quite frankly, it's their body and they're the ones that go home with the end result, whatever it is, and the doctor doesn't.
Thank you very, very much to all of you. All of you have emphasized the critical role of information, of widening access to testing to get more information, of improving communication with various members in the team. And I think all of you have contributed enormously to the flow of information through sharing your insights over the course of the past hour. Brianne put it as getting the word out, and you've certainly gotten a lot of very important messages out there. So many, many thanks for participating in our discussion, Ryan, Robert, Brianne, and Joel. And dear ladies and gentlemen, that does wrap up this LinkedIn Live event on innovations in diagnosing and treating cancer, barriers to patient access. I would like to say also to you, ladies and gentlemen, thank you so much for your attention over the past hour, and also for your contributions on providing us with some great questions to think about. And as if you didn't get a chance to pose your question, as I say, I am sorry about the time limitations that we faced. If anybody missed anything and would like to hear our discussion again, you will find a recording on YouTube, and we will post the link on our LinkedIn event page. And let me also say a very warm thanks to Bayer for making our discussion possible in the run-up to ASCO 2021. And again, we're very, very grateful to have had this opportunity. I wish everyone a good afternoon or evening, depending on where you are. Stay healthy, and goodbye.
Thank you.